Good evening. Welcome to the 28th Dolan Lecture, which isn't hard to believe, and I thank you very much for coming. There's a reception right after the lecture tonight. I hope you'll join us, and I'm going to ask Dr. Crenny to introduce tonight's speaker.
Hi there, I'm Dr. Patrick Carenti. Nice to see you all here. Gosh, I've been thinking back. This is the 18th year I've been on the Dolan Lecture Committee, and it's been great. We've gone through so many amazing speakers. One that was going to restore my hair transplant, but that didn't work. So another that was, just amazing with the NFL and the concussion syndromes and people who've done amazing things with HIV and AIDS. And Dr. Lucey and I were just talking before about the wards, and Christina Baselga will remember the wards that we had in 1998, or 1995, at Georgetown, when we first started, the wards of the HIV patients, in, what was it, 6 Bless, or 7 Bless, that were just filled with HIV patients that no longer exist because of the work that scientists like Dr. Lucey did to help cure these patients and keep them out of the hospital. And patients with HIV 50 years later are still working. And these doctors, infectious disease doctors dealing with emerging diseases, are just really doing so much to help what we are doing today. So it's a pleasure to introduce Dr. Daniel Lucey today. He's a graduate from Dartmouth College and Dartmouth Medical School, then went to the West Coast to UCSF to do his residency in internal medicine. And I guess he liked the East Coast so much, he came back to Harvard University and deal with the cold for his winters and fellowship in infectious diseases, and did HIV AIDS work in Texas until the late 80s into 92, where he moved to the DC area, working at NIH and the National Naval Medical Center as a consultant for the Center for Emerging Diseases and Biodefense, and as an adjunct professor at Georgetown University Medical Center. He comes tonight to discuss with his hands-on experience in Ebola in West Africa and the devastation it has left in its path. And I'd like to say, I'm so proud tonight. Also, I have a student of mine who's visiting, or actually not visiting. He did his undergraduate at George Mason University. He is from West Africa, from Burkina Faso. And if you haven't looked at it, you need to look at a map, because I did. But it's West Africa above Côte d'Ivoire, and his name is Arnaud Yonago. Stand up, Arnaud. And his country has been lucky. Although they're West Africa, they have no Ebola crisis, and they've been immune to the disease, although it's very common in that whole area. And it's an amazing contracture of the disease and containment of the disease. And it was a little bit of, you need to come to the lecture, because if you want a recommendation, you need to come to the lecture. But, no, just teasing. Anyway, so I am happy to introduce Dr. Daniel Lucey from Georgetown University Medical Center. Thank you.
Thank you very much, Patrick, for that kind introduction. It's a real honor to be here this evening, and I'd like to thank everyone who took time out of their busy schedule to be here tonight. I'd also like to thank the Dolan family, John, Bill, Carol, Jack. Although I was never fortunate enough to meet Dr. Dolan, if I had, I'm sure he would have been someone that I would have greatly admired for his decades-long commitment to his patients, to the advancement of medical knowledge, to education of students and trainees in medicine, again for many, many years, and also for his military service. Something that I greatly respect, having grown up in the military and served on active duty myself. So what I'd like to talk about tonight, and I'm glad to take questions at any point along the way, although I will certainly leave time after the slides for questions, but please ask questions during the presentation. I do have a fair number of slides. A lot of them are pictures, especially after the first few slides. And then I have about a 3.5 minute clip from a 55-minute video that PBS Frontline produced on May 5th of this year about the outbreak of Ebola, starting in December of 2013 in Guinea and going forward until September of 2014. And the 3.5 minute clip that I'll show is from the Doctors Without Borders, or so-called MSF, Médecins Sans Frontières, Ebola treatment unit. I won't call it a hospital. It was tents with a mat on the floor of the tent for a patient with 3 buckets at the foot of the mat for 3 different body fluids. So that's why I won't call it a hospital, call it what it was, Ebola treatment unit. It's the largest one that's ever been built for Ebola. The video only go up till September of 2014, and I arrived there at October 3rd until November 14th. But there is a video from inside the Ebola treatment unit, which otherwise I don't have. I have pictures from patients who were there, but not from inside the tents. And so one of the things I really want to emphasize from the beginning is that conditions were very, very bad for the patients and for the countries, for the society, especially in the early months. And there were a lot of early months. But conditions did improve, and there were many more survivors. And so the title of my slide is an attempt to reflect that reality. So the enduring agony in West Africa, Guinea, Sierra Leone, Liberia, and what I can honestly say was joy of helping patients survive. I'd like to start off by dedicating the lecture to a Sierra Leonean healthcare worker who worked at the hospital where I worked, although at a different time in Freetown, the capital, Dr. Martin Salia. He had a special link to Georgetown University in terms of a program that Georgetown has in Cameroon in West Africa. He's originally from Sierra Leone. He went back to Sierra Leone to work with patients who had Ebola as a surgeon, and tragically he got infected and he died, leaving behind his wife and 2 children who lived nearby in Maryland. There's a special memorial service at Georgetown in January for Dr. Salia. In terms of numbers, I just want to emphasize that there's a big contrast between what happened in West Africa with regard to Ebola and what our experience was in our country. In West Africa, there have been more than 880 healthcare workers in these 3 countries, Guinea, Sierra Leone, and Liberia, who were infected with the Ebola virus, and over 510 of whom died. In the United States, fortunately, no U.S. citizens and therefore also no healthcare workers have died of Ebola. Dr. Fauci from the National Institutes of Health, the head of the National Institutes of Allergy and Infectious Disease at one point around now last fall when I was working in West Africa with so many patients, he said that there's certainly an epidemic of Ebola in West Africa, But there's an epidemic of fear about Ebola in the United States, and I agree with that. This is my career, 33 years since 1982, all in one slide, and I won't dwell on it. But the point that I'd like to make is that for me, this is what I do. This is what I enjoy doing, which is to go to where the viruses are, go to where the outbreaks are. And I think that's partly from being a medical intern just out of medical school in San Francisco in 1982 till 1985 when the HIV epidemic was just starting. And because it was so new, our teachers couldn't teach us about it. And so for me, going to where the outbreaks are, whether it's Hong Kong or Guangzhou or Toronto during SARS in 2003, or bird flu in Indonesia, Vietnam, or Egypt, pandemic flu in Egypt, in the Middle East respiratory syndrome, MERS, throughout the Middle East, and then this summer I went to Korea when there was an outbreak there after a businessman returned from the Middle East. Then there's a new outbreak of a different type of bird flu that occurred in 2013 and is starting now for this fourth cycle in eastern China, and then Ebola. That said, Ebola is different. It's different. Different in two main ways, I would say. One is that in a good way, it's not spread through the air, which the SARS virus was, SARS pneumonia, the MERS virus is, but it's not spread through the air. So it's, in a sense, less contagious. It requires direct contact with body fluids of someone who is sick. But also, the personal protective equipment for Ebola is different than for all the other infectious diseases. And in a very important practical way, and that is that you are not able to work with your patients for very long. So as I'll mention a little bit later, when I first got to Monrovia, the Doctors Without Borders, I'll refer to them as MSF from their French acronym, Médecins Sans Frontières. The rule was, and you had to follow the rules for everyone's safety, because my safety was your safety was our safety, all of us working together. You can only work for 45 minutes in the morning and then 45 minutes in the afternoon, wearing the equipment in with the patients. But when I first got to Monrovia, October 3rd, there were 136 patients and 3 doctors. Lots of Liberian nurses and some physician assistants. But basically, each of us, there was a doctor myself, a doctor from Sweden, a doctor from South Africa, were responsible for about 45, 46 patients, 45 minutes. No intravenous fluids. No laboratories. We couldn't measure potassium or sodium, which in my view would have helped save patients' lives, because with the vomiting, diarrhea, profuse sweating, you have marked electrolyte abnormalities, particularly of potassium and sodium, but we didn't have the capability to measure them. No intravenous fluids. But patients live because of being able to, if you could give enough oral rehydration solution, ORS, which is basically just water, sugar, sodium, and potassium. It's the exact same treatment that's given to patients with cholera that saves patients' lives with cholera, because Ebola causes terrible diarrhea as well as vomiting, much like cholera. So someone had the brilliant idea that you could use this oral solution with potassium, sodium, water, and sugar to save patients' lives. But first you have to stop the vomiting and the diarrhea, or you do it in parallel. You give medicines to stop the vomiting and the diarrhea, and the one rule I made is that all the patients have to be out of the tents by 10 a.m. when it starts to get extremely hot, because otherwise literally you could sweat to death. Because again, the tents were not air conditioned. So no IVs, no measurement of any laboratories, no temperature control. I wasn't asking for air conditioning. Nobody wanted air conditioning. You just wanted it to be not searingly hot. But all that said, we had a lot of survivors once we figured out a way to help the patients drink more of the oral rehydration solution. So I'd like to go through the first couple slides pretty quickly. So this is from April or end of March, March 23rd, when the World Health Organization first had the laboratory confirmation that the cause of the outbreak that had been going on already since December in the forested region of Guinea and then spread over the borders into Sierra Leone and Liberia, that it was due to Ebola virus. It was thought to be due to cholera. Why? Because of all the diarrhea and because Ebola had never been in West Africa before. Since 1976, there have been 23 outbreaks of Ebola, but never in Africa, but never in West Africa. In addition, there just weren't the laboratories that could do the tests for Ebola virus. And so the first diagnostic test that showed that this was Ebola virus epidemic was performed in France. Patients' blood that was flown from Guinea to France. So in the very beginning, here's the map in red where the outbreak had occurred. Here's Sierra Leone in the middle, here's Liberia here, here's Guinea here. So it started right in the border region. And so almost right away, 3 countries were involved. And what happened is that also almost right away, patients were transported, if you will, on their own or by whatever means to the capital cities, because that's where the best medical facilities were available. In all these prior outbreaks I mentioned since 1976, there had never been Ebola outbreaks in the capital cities. They were all in rural areas, or almost all in rural areas, never in capital cities. Maybe small towns, but not in capital cities. So why does it matter? I'd say 2 main reasons. One, if you only think about it from our American-centric point of view, is capital cities have international airports. And rural villages where outbreaks occurred previously in Africa since '76 don't. So there's an outbreak in rural Uganda, rural Zaire, rural Sudan. Nobody's going to get on a plane and fly to Washington or to Dallas or to New York City. But now all 3 capitals. So sooner or later, somebody's going to get on a plane and fly to Europe, fly to the United States, fly to elsewhere. And as we know, that happened eventually at the end of September in Dallas. But in addition, it's very important that now capital cities are involved, because how do we control, how have we traditionally stopped Ebola outbreaks? There's no treatment. There's no specific antiviral drug or antibody or vaccine. So it stopped the same way the SARS epidemic was stopped in 2013, the same way the MERS outbreaks have been stopped in Korea recently, the Middle East. Isolate people who are sick, give them the best supportive care you can, and by isolating them, that they don't transmit the virus to anybody else. You quarantine people who have been exposed, and if they get sick, then you isolate them. But again, you're trying to prevent person-to-person contact by preventing person-to-person spread of Ebola, by preventing physical contact with the body fluids of people who are infected. And since it's not spread through the air, that's all you have to do. Sounds easy, and it's always worked before since 1976 for 23 times in rural outbreaks. Now you have many people in the cities who are infected, and cities where not everybody has an address, not everybody has a home, and there's a lot of physical contact out of necessity and out of tradition. And when someone's buried, then when someone dies, the burial process is different than what routinely occurs in this country. There's a lot of physical contact with the person's body after they've died. But the body fluids have the highest amount of virus. As someone gets sicker and sicker and sicker, the amount of virus gets higher and higher, and the virus persists and it's infectious for days after death. So the burial process often triggered infections in many people. But again, this is a part of the culture, so it's very, very hard to change that culture. But eventually, it was changed by the people who live in Guinea and Sierra Leone and Liberia. So a lot of people who look like me and come from our country and from Europe, and I worked with people from Brazil and Hong Kong and Afghanistan and Pakistan and many places, came to West Africa, but the epidemic was primarily stopped by a change in behavior by the people who live in Guinea and Sierra Leone and Liberia. So again, I think the fact that the virus had come, I speak of the virus as if it's autonomous, but obviously people who were infected came to the capital cities for treatment, and that changed everything. This is already just 10 days after the initial report. March 23rd, 3rd of April, the virus is now in Conakry, the capital of Guinea, and very soon after Monrovia, the capital of Liberia. Also, I want to emphasize that this is from the World Health Organization. By April 3rd of 2014, they had changed the name of the disease. Always before, it was called Ebola hemorrhagic fever. But in fact, patients rarely hemorrhage. So that's wonderful news. because there's no possibility of giving blood transfusions or of stopping the hemorrhage. If you can't give intravenous fluid, you can't give transfusions. And so the World Health Organization calls it Ebola virus disease, or EVD. Again, that's very important because, again, the cause of death was dehydration from vomiting and diarrhea and sweating to the point where you develop shock and the kidney shut down and the heart shut down and the liver shut down and you died from that. So if you can just prevent the patient from going into shock by giving them enough fluid so that they can stay alive, and every day they're alive, their immune system is fighting off the virus, fighting off the virus, fighting off the virus. So in my view and experience, I would say if you could help a patient stay alive for 8, 9, 10, 11 days, then their immune system has fought off the virus enough that even though there's some virus still there, now they're able to eat and drink on their own. And they're almost certainly gonna survive. Except I would say maybe 10% of patients who died suddenly. And I think it's because their sodium or potassium were very abnormal, and that caused a problem with the heart rhythm and with the brain, and sometimes the kidneys failed. And so back on 8th of April, along with 2 colleagues, one from Virginia, an emergency medicine doctor, and one from Minnesota, and then the 4th one from New York City, who didn't want his name used, so that was fine. I wrote some frequently asked questions that then was sent out to, through the hospital preparedness program in the United States through the Health and Human Services headquarters here. Because we didn't have much information or knowledge or any experience with Ebola in America. So I thought this would be a good thing to do. And I emphasized in the beginning that the virus was now in the capital cities, and I know that because I misspelled the name of the capital of Guinea as Conakry instead of Conakry. And I got about 7 emails from different states saying you misspelled the name of the capital of Guinea. So at the time, I was happy, and I still am, because it means that people read what we sent out. So that was good. But I was embarrassed that I didn't spell check, the capital of, how to spell the capital of Guinea. It took until August 8th for the World Health Organization to declare the Ebola outbreak in West Africa what's called a public health emergency of international concern. And I don't know anyone who today doesn't think that that was delayed, that declaration of a public health emergency of international concern wasn't delayed too long, that it should have occurred sooner, because it galvanized international support to work with the people in Guinea and Liberia and Sierra Leone to come start and continue over a long time, many months, and now it's been more than a year. It's almost, it'll be 2 years next month since the outbreak started in Guinea, and eventually to bring it under control. There are still new patients today in Guinea. It's not over in Guinea. Sierra Leone on November 7th, just a few days ago, was able to say that as far as they know, it's over now in Sierra Leone. And Liberia did the same thing just a couple months ago. But then there was a new case in Liberia a few months after it appeared to be over, because it turns out that the virus can persist in certain, we call immune sanctuaries of the body. So in the eye, in probably a small percentage of patients, but also in the semen of men, it can persist, even up to 9 months. There was an article in the New England Journal of Medicine recently about that. So Ebola can be sexually transmitted if you're having unprotected sex, the virus being in the semen of men. Not all survivors, but in a significant percentage. So, Sierra Leone. So I was very, very happy to finally be able to go over. This wasn't like other outbreaks, so I felt comfortable just going on my own and thinking, oh, I'll meet someone, I can just go. But Ebola is different largely because of the personal protective equipment. So I spent 3 weeks there in August in the capital in Freetown, worked with the Ministry of Health. The most senior most senior nurse for the Ministry of Health of Sierra Leone is shown here on your left. A doctor from the UK who I was working with is shown here, and in the next picture, and what the doctor from the UK did, and then asked me to take over after about 3 days when she had to go back to the UK, was to work with the Ministry of Health to train nurses and doctors in the capital on how to put on and safely take off the personal protective equipment. And it's taking it off that's important, because that's when the virus is most important, because that's when the virus is on the equipment, and if you get it on your hands or touch your nose or your eyes, then you can get infected. The only way that I could teach it, which is what we're doing here, And what I tried to do was train the trainer, if you will, train folks in healthcare workers in Sierra Leone, because like the doctor from the UK, I would very soon have to return or would return to my own country. But they were fighting the epidemic in their home country, and they would continue to do so for many months and now more than a year. So that's what we did, and over the course of about 8-9 days, we were able to train more than 120 persons, and then they went out and trained other people, including outside of Freetown. Again, remember that number of 880 healthcare workers infected with Ebola in West Africa, which if you add the healthcare workers from Nigeria and Mali who are infected, it comes up to pretty much 900 who've been infected, and more than 500 have died. And largely that's because of lack of adequate personal protective equipment and lack of adequate or sufficient training on how to put on and safely take off the personal protective equipment. So for me, it was a huge honor to be able to participate in a small way over a small number of days in August of 2014 in Sierra Leone with helping the very brave healthcare workers who, some of whom had already been working with the patients, but they hadn't gotten good training, so they came to the Ministry of Health in Freetown for the training and then went back for day after day, night after night, week after week, month after month to take care of their patients. This is the hospital I worked in, Freetown, Connaught. Again, it was so different from the United States. So this was a hospital. They had one special ward. It was called the Ebola Isolation Unit, but there was no isolation. It was 13 beds, one right next to the other. There's no isolation, and there were body fluids everywhere. The isolation was, I said, where's the isolation? They said, well, the isolation is we're isolating the suspected Ebola patients from the community. At this time in Freetown, Sierra Leone, also there was no laboratory test available to test for Ebola. And also there was no treatment available. We didn't have oral rehydration, nothing. So what do? You draw the blood, you try to find a person who can drive the blood sample in a vehicle 4 or 5 hours away to the eastern part of the country where the outbreak is really raging, a place called Kenema in Kowloon, where there is a lab. They can do the test. Sometimes the vehicle didn't have gas. So someone had to pay to get the gas to, the driver had other things to do. So what I'm trying to emphasize is that it could take 3 days or 4 days from the time you draw the blood till you get the lab result. That's terrible because there's no treatment for the patient where you are. And once the test comes back positive for the patient, then the patient has to go in the vehicle 4 hours away over bad roads to a very crowded treatment center in the eastern part of the country. And Ebola kills you very fast over days. So if you're not getting adequate hydration, you'll die. The last thing I want to say that is very striking from any medical experience I've had anywhere else in my life here or overseas was that the patients who came to the so-called isolation unit or who were brought there and were, so if I have Ebola and the person next to me doesn't have Ebola, they have malaria or typhoid, let's say, and so they have fever, vomiting, diarrhea, same symptoms. But my body fluids are mixed with their body fluids on the floor or on the beds or on the handrails. And so someone comes in with, so if I have Ebola and you don't have Ebola, after 3 days or 4 days of being together and exposed to my body fluids, now you have Ebola. But your test comes back negative. And so what was happening was, we say, congratulations, your test is negative. So now you can go back home. The first dictum of medicine is do no harm. We were doing harm. And worse than that, if there is anything worse than that, then there was no follow-up of those patients who had been exposed, some of whom probably were infected. So they should have been followed to see if they got sick. And if they did, they would be isolated so they didn't infect their family members or their colleagues or their people that they come into contact with at the market or in school or at work. This is the reality, and I'm not proud to say it. And it's not in any kind of judgmental manner. I'm just stating this is the reality, the way it was. It changed, fortunately. But this is the way it was. So for me, there's these internal ethical questions. Like, should I continue to be here? But honestly, for me, that question didn't last. It got answered quickly, which was yes, because hopefully you can do some good to help things change. But the reality is that until they changed, some patients were being exposed to the virus who didn't have it when they came in. But eventually things did change, and treatment became available. There was a laboratory that became available to do the testing, and so we made a new rule. We aimed for 12 hours, but we said nobody stays here, no patients stay here for more than 24 hours without having a lab test. And we tried to move the beds farther apart, and we tried to bring in the bleach more often to kill the virus in the body fluids so people weren't exposed to infected body fluids. So that you have to do the best that you can do. That was my answer to the question. Should I leave now? So I made a list of, before I left in August, of 18 problems. I show you just a few, and 18 solutions, because nobody wants to hear problems without solutions. And nobody really wants to read more than one page, and they don't really want to turn over the page. So it's whatever I can get, small font on one page, one column of problems, one problem of solutions. Solutions don't have to be the best, but they have to be something. It's the best you can come up with. So one thing that also bothered me, another question I asked myself, should I be here or should I stay here, is that the personal protective equipment was not good. It was very good later in Liberia with Doctors Without Borders. It was not good here. The gloves were not the right kind of gloves. They'd come down around your back of your palm, back of your hand. They didn't stay up above your wrist. And we had white protective equipment. The MSF is yellow. And it would come down to this far so that you'd have exposed skin. You never want to have exposed skin. The virus likes that. You don't want to do that. So we take the white sleeve, and you shouldn't use sharp objects. So I'm saying what you shouldn't do. You shouldn't do it. But if you have to do it, then you have to decide, are you going to do this or not? So we took a sharp object and we jabbed a hole in the sleeve, and then took our thumb and put it through the sleeve. So that kept the sleeve down over your wrist. And then we took some tape and we taped these little exam gloves. No surgical gloves or anything that came up high, like with MSF. That's the reality. That's the reality. That was the reality. It changed. It got better. So I pretty much mentioned here the problems. There's no treatment here. There's no laboratory test. There's no ambulance. It's like there weren't hospitals really. It was no ambulance. And we had a baby whose parents were dead. Baby had Ebola. And so how do we get the baby to 5 hours away by car to the treatment center? There's no car seats. There's no baby seats. How do you do it? And the patients, okay, there's patients, but they're so sick and on their way to, many of them, to dying. So they're in the back of the ambulance with the baby, but you can't ask them to hold the baby and safely take care of the baby. So what do you do? Same thing. What do you do? You have to have a solution. So you have to come up with the best solution you can come up with. And if you have a better one the next day, then you apply that. So our idea was to send somebody to the market to buy a basket, and then we filled it with paper, and then with some kind of a blanket, even though it's hot, because there were some sharp edges to the basket. But and then we put the baby in the basket, and put the basket in the back of the vehicle, and we asked the patients to just try and not let the basket slide out the back of the door when they open the door. So I called it the baby Moses basket. And that baby did survive to get to Kenema to treatment, but soon after died. So imagine a baby. If a baby can't get fluids, someone to help the baby to get fluids, the baby will die for sure. So as bad as I'm describing the situation in August in Sierra Leone, it was much worse in August in Liberia, in the capital, Monrovia. Many, many more patients. An entire part of the capital of Monrovia, it's called West Point Slum, was cordoned off by the government because of an outbreak of Ebola there. And that led to demonstrations, if you will, and a 16-year-old was shot by the military and died. And so in Sierra Leone, in the capital in Freetown in August, we all knew from the news what was going on in Monrovia, and the phrase that was said over and over is, we cannot let Freetown become Monrovia. But that's what happened. So in August and September, in October, the center of the epidemic, the epicenter, if you will, the Ebola epidemic was Monrovia, the capital of Liberia. In November and December and January, it was in Freetown, the capital of Sierra Leone. So remember, capitals. Virus had never been in the capitals before. And it turns out you can't control it by isolating people who are sick in quarantine. You can't control it very well, adequately, by isolating people who are sick, quarantining people that are exposed. Because you can't do the contact tracing to see who's been exposed and putting them into quarantine. Because you can't find everybody. And you have to find everybody and do contact tracing for everybody. But you can't do that in large cities, especially when people don't have addresses. And on top of that, understandably, in my view, many people didn't want to be found. Because they said, well, why should I go to an Ebola treatment unit? You don't have any specific treatment. And then if I die there, then I get buried in Sierra Leone by the government in a certain Ebola burial area. But in Liberia, between August and December, the president of the country, who I greatly admire, President Ellen Johnson Sirleaf, and I was able to meet when I was there, I admire her greatly. She made the decision that between August and December of 2014, every patient who was suspected or confirmed of having Ebola would be cremated. So that takes the risk of transmitting the virus through the traditional burial, to zero. But to be cremated, it goes against the culture of almost everyone, every religious faith, traditionalist, Islam, Christian, or other. And then, where's the grave? Where do you go to pay your respects to your family members, to honor the dead? There was the first child who was 4 years old, not the baby, but a 4-year-old. There's only one big pediatric hospital in Sierra Leone, it was in the capital. This was it. One day after the first child was found to be Ebola positive. And that child was sent to our Connaught isolation unit. And in 24 hours, the entire pediatric hospital was closed. Where did all the children go who were there? And you have to be very sick. In this country, you have to be very sick to be in the hospital, but there you have to be even sicker. So where did they go? They had to go home. They had to go, a lot of them most likely died because they weren't able to get continued medical care. But the healthcare workers had no training. They had no personal protective equipment, no training on how to wear the equipment. It wasn't safe for them. And it was very powerful. And they asked us, can we come here, or can they come to the Ministry of Health to get training on personal protective equipment? I spoke with a number of people in Sierra Leone at the time. This was the Minister of Health in red in the middle. This is the head of the Doctors Without Borders in Sierra Leone. I wasn't working for them at the time. This is the head person from World Health Organization. There were people from the US CDC, people from the United Nations, Dr. David Nabarro, who I greatly admire. His first week on the job, he got on the plane and came to each of the 3 countries. The head of the US CDC, Tom Frieden, other people from WHO, Geneva headquarters came. And I went up and talked to each and every one of them. Normally I'm very quiet and reserved. I would never walk up to such important people who I didn't know and basically start just talking directly to them in a very strong way for a long period of time until they asked me to stop. Because I thought, they have the authority. And they have the power to make things change in the way that they have to change right now, this hour, this day, this week. But it didn't happen. This hour, this day, this week. Eventually it happened. So I came back in September, beginning of September, and there was no quarantine because the events that happened in the Liberian traveler to Dallas later in the month hadn't happened yet. So Georgetown was happy to have me come back on campus to give some talks. I didn't shake hands with anybody or have any physical contact, and I checked my temperature 3 times a day, not just 2. I wrote it down in a fever diary. These are things I routinely do when I go to outbreaks overseas, so nothing different. And the US media was quite interested in talking to anybody, they don't particularly like me, but anybody that had been in West Africa working, including all these news outlets. And front page of the New York Times, September 20th, emphasizes how things are getting bad in Sierra Leone now. And the government's doing a lockdown. You can't come out of your house, and they're sending people to the cities, to people's homes, and talking to people that don't have homes, trying to find out if they have a fever, and if so, then they put them into isolation for possible Ebola and test them. So moving along then to Liberia. So the video I'll show is of the Médecins Sans Frontières, the Doctors Without Borders Ebola unit in Monrovia. It opened in the middle of August, when it was the epicenter of the disease. And honestly, I'll say this honestly, that I don't think I could have done the work that the people who were there then did. And if I had to do it, then I might have left, or I would not have been able to recover from it. And what do I mean by that? There were so many patients, hundreds of patients outside. This is the main gate, literally. Here's the orange fence. That's what you only see pictures of. It's inside the orange fence is where the patients are. So this is outside at the main gate where patients, and there's big walls here. So there's very many patients there, many more than the number of mats on the floor of the tents for the patients. So all the mats for the patients are full of patients, but there's still dozens or hundreds more patients. So what do you do? What do you do? So these 3 people, 2 Liberians and 1 expats from Europe or wherever, the States, they have to decide who comes in. The gates are only open for 30 minutes every 24 hours in the morning. So why 30 minutes? That's as long as it takes to let in the number of people that matches the number of patients who died the night before. Meanwhile, they were building and building more tents, adding more mats. But in the beginning, it wasn't enough. So how do you make that ethical decision? You know, parents with their babies saying, "Okay, you can't take me, just take my baby." How do you do? And then from a public health point of view, so that's all of us who are healthcare workers. You think about the individual patient. But what about the public health? What about the transmission of the virus, the ongoing outbreak? You have to break the chain of transmission. You have to stop people from exposing other and infecting other people. So maybe some of these patients had malaria or typhoid or something else, but they're in direct contact with people that are sick who have the virus. And then people that are here who have Ebola, but there's not enough mats on the floor of the tents to let them in. Maybe the first day they wait and they think, maybe I'll get in the next day, or my baby will get in the next day. And the third day, no. Eventually they're going to die or leave and die, but and some will survive, but not a high percentage, not very many. But they'll expose other people who are taking care of them in the community. So it's an amplification of the epidemic. 30 minutes every 24 hours. So this was August into September. Fortunately, from a purely selfish point of view, from my point of view, when I got there with a team of folks, we flew in from Brussels, from the MSF headquarters in Brussels. We had enough tents with mats now. So nobody was waiting outside. Everybody got admitted. And now they'd built up to 250, 10 tents, so it could hold up to 250 patients. we had only 136 patients. So this is the biggest Ebola treatment center ever built. To my knowledge, it was the biggest number of patients, but that's not anything to be really proud of. But I'm just emphasizing the numbers again. As I said in the beginning, there were 136 that first day. There were 3 of us with large teams of Liberian doctors Liberian nurses and physician assistants who did all the work. There were no Liberian doctors working here. There were some working at a different facility, doing a great job, one of whom was on the cover of Time magazine last December as Time Person of the Year, along with several other people who had responded to the outbreak from in-country or some expats. Everything that's inside, everything, I mean all the equipment, the patient's body fluids, the food that's left over, the bottles of ORS that are empty or not empty, everything that's inside the hot zone, meaning where the patients are, gets burned. Nothing can come out because it has virus. It's potentially contagious. So it turns out, I didn't realize this, but so sometimes we had to work at night. And so the virus burned all day long, and they burned at night too, because apparently plastic and other material, it's not stopped by the rain. And so it's a rainy season, so it rains every day, which is good because it cooled things off a little bit. But the first night I worked, there was a thunderstorm, there was lightning, there were fires. And when you work at night, there's only one expat healthcare worker. And so you're responsible, a doctor or nurse, to see all 10 tents and all the patients. Well, one thing is you never wake up a patient who's sleeping who has Ebola, that's for sure. But a lot of patients can't sleep because they're so sick. So you have a lot of work to do. And it's been a long time since I had to be up all night working in hospitals. So I was a little bit worried the first night that I wouldn't be able to stay awake all night. And if you're caught sleeping, then you're put on the plane back to Brussels. Well, after 1 hour that night, I knew I was going to be awake all night, no problem, because you're it. You're it. You have a lot of work to do. To me, this is getting to where the joy starts. This is working with our Liberian colleagues. And a small percent of the big number, over 600, who worked there 4 shifts, 3 shifts, worked around the clock, the 4th shift rotated off, and then they came back the next day, 7 days a week. Very importantly, if anyone gets infected with Ebola, then you put everybody else at risk, right? Because it's a contagious disease. Even though there's strict rules, you never have contact with anybody, healthcare workers, never. And we stayed in hotels, we stayed in individual rooms, you didn't shake hands, we didn't even do what World Health Organization says, bump elbows, no contact whatsoever. 2 people decided to have contact outside of the work environment, and they were fired. They were put on a plane back to Europe. So your safety is my safety is our safety. That was our motto, one of. So now I'd like to show just a 3-minute, and then I'm going to show pictures, really, that are wonderful pictures about survivors. But I'd like to show a 3-minute video from May 5th PBS Frontline of this facility where I worked. And it was called ELWA 3, ELWA. There was a 1 and 2, but this is the 3rd one. And ELWA. It stands for a part of Monrovia, the capital, that has been in existence for decades. It's not just because of Ebola, this name, which you'll always remember when I say it. ELWA, ELWA 3. Eternal Love, Winning Africa. Eternal Love, Winning Africa, ELWA 3. Okay. So this is the sky view of, I don't know if there were planes or drones or what, but this was ELWA 3 from the sky. I'm going to go over here and enlarge it. Sorry.
As West Point descended into chaos, Doctors Without Borders have been constructing ELWA 3, the biggest Ebola hospital ever
we're going to turn on the volume, sorry.
But when it opened, it was immediately clear.
So this is August and September. Coming through that main gate that you saw.
Turn the volume.
Oh, can we turn the volume back up now, please?
People were dying outside Families were dying in taxi cabs outside. They were arriving, seeking care. The families had nowhere else to go. The centre was full, and essentially they were the centre was waiting for someone to die to then make space.
Stefan Liljian was recruited on short notice to work at the clinic. He had no Ebola experience.
I arrive and there are mattresses just next to each other, full of people, and they're dead. And I look at them and okay, so that's how a dead person looked like. They're telling me that, Stefan, we can't just watch, we need to go in and move bodies. Are you ready for it? And I start to panic and my pulse goes very high. There are dead bodies in there and in gruesome positions. We go to the next one and there are dead bodies in there as well. And we go up to a man in a chair. The guy with the spray goes up and he starts spraying his face, and that's when it really hits you. Yeah, he is really dead. And we place out the body bag and zip him up, and we carry him away. And family are crying and screaming and yelling, and many are in panic. That was my first day with Ebola.
A normal medical round for me would be going in, pronouncing 5 or 6 people dead, and it's extremely horrible because people are dying, sometimes very distressing deaths beside a child. The mother that was trying to care for her child dead, and then you've got a baby, and trying to work out how on earth are you going to try and deal with an unaccompanied child in an overfull centre. It was really hard. It's just so far beyond what could normally be expected of humanitarian workers, I would say. The pointlessness of it, that's what it felt like. You know, normally if you work to the point of exhaustion, you can come away from something and feel a degree of satisfaction, knowing that you did what you could. I didn't feel any satisfaction at all. It was never about feeling like you failed in the level of medical acuity. We did everything we could. It was about feeling the shame of what the world had to offer for Liberia at that time. And yeah, the sheer number of death. It was just really seeing death.
After sleeping on the streets for 5 days, Finda and her surviving children were finally picked up by an ambulance crew in West Point. They were taken to the new clinic, but when they arrived, there was no room for them.
Anytime I pay, I say go. Yami now because you only give me my 1 hour.
That was August and September. Now I'd like to move into October, where things improved a lot, and even more in November. And now comes the joy part. Patients continued to die, but in many smaller numbers, and the ratio of people who survived to people who died went way up. Many more people survived, and many fewer people died. And that was partly because the epidemic itself was starting to come down because of the change in behavior that was taking place in the communities and the cities. Inside this particular facility, what we tried to do was to emphasize now, starting October the 11th, I made this one-page poster, called it 4 Steps to Help Our Patients Survive Ebola. And it was really just a description of the 4 conditions that we found the patients in, which is that you couldn't sit up, so you can't drink ORS, so you'll die, unless you have someone help you, like this person. So we hired an artist from Monrovia to make these drawings. Then you could, sex stage, you could sit up, but you couldn't drink enough on your own, you'd die, unless someone helped you. And then the 3rd stage is an important stage, because now you can actually walk out of the tent where it's so hot, and you can drink and you get a little bit of appetite, but you still need someone to help you eat and drink or you'll die. And the fourth step is what I call the pre-survivors. You can take care of yourself completely. The virus is still in your blood, so you're not a survivor, you're not able to leave, you're still there. And finally, it occurred to me that while we can only go in for 45 minutes in the morning and the afternoon to help people drink ORS, basically, and to give them medicines and everything else, the pre-survivors were there 24 hours a day, 7 days a week. And they knew what it was like to suffer and almost die from Ebola. So we started asking them to go back in the tent to help the people who were too sick to get up and to be able to drink and to get out of the tent. So the phrase we coined was simply this: the stronger help the weaker. We ask the stronger patients to help the weaker patients. So more patients become survivors of Ebola, go back into their communities, and hopefully be accepted back. In reality, it was like AIDS and so many other new diseases. The stigma was terrible. So people weren't always welcome back, but that was the goal, and sometimes they were. So the stronger helping the weaker, because they're there 24 hours a day. And I would say 3 out of 4 of the patients, the pre-survivors that we asked to help, the weaker patients, they said yes. Sometimes for children, we had two pre-survivors help the children because they needed so much help. So then also I realized that the tents were sweltering hot. So by 10 o'clock every day, we had to get the children out. It was really this young boy, 5 years old, who came in with his 14-year-old sister, side by side, mat by mat. 14-year-old died in less than 24 hours. Nobody else in the world to help this 5-year-old. He was too weak. He couldn't even drink the ORS. I'd pick him up, try to help him drink, but he had terrible blisters and ulcers in his mouth and his lips, and he was extremely weak and malnourished to begin with. And finally, one day, what happened was that we went in to see him, and he was still alive. 2 days, 3 days after his sister died. Someone put a juice box, like we all know juice boxes that have a straw, plastic straw taped to it, next to the head of next to his head. And he was completely unresponsive. And suddenly, I was very happy, but also again felt guilty. That was often the feelings that I had. It was like guilt and happiness. And I felt guilty because I didn't think about the juice box. But immediately I took out the straw and I put it in the juice box and I put it into his mouth. And his eyes were closed. He wasn't moving. And suddenly he started to pull in the juice. Really hard, really strong, really long. It was one of the happiest moments of my life. Because what happened was obviously we gave him more juice, then he was able to drink ORS. And suddenly I picked him up and carried this. It's the only picture I have of me wearing PPE. That's my name up there. You put your name, so as if the patients will know who you are, but sometimes maybe they will. So you put your first name up there. They call you by your first name, Dr. Dan. So I carried the child out here, and if we're looking out from inside here, this is where the main nursing tent is. So it's not the hot zone. It's a safe area. So you're looking out and you're seeing the tents where patients are. And I brought the 5-year-old child to the edge here so that everybody could see him, because we all knew him and we felt terrible that he was going to die like his sister died. And we tried to help him, but we couldn't give intravenous fluid because the argument was that there were too many patients. And so ethically, you couldn't decide who could get the IVs and who couldn't. And so we didn't give them to anybody. So clearly, the children, such as this child, was going to die. But suddenly, he drank the juice. So after this, we gave other children juice. We gave him juice, then we gave him ORS. And I said, everybody's got to be out of the tent in the morning. We're going to change things here. We're going to focus on survival. And survival comes down to drinking enough oral rehydration solution. That's it. In that sense, there is a specific treatment for Ebola. You don't die of hemorrhage, you die of dehydration and shock. In a way, that's good news, because you can prevent dehydration and shock, even with just oral fluids without IV. These are some of the stronger patients that help the weaker patients, called the pre-survivors. I won't go into great detail here, but basically we gave what I call directly observed therapy, like for tuberculosis, for the medicines to stop the vomiting and the diarrhea and the pain, and we treated for malaria. We gave a lot of medicines. Mostly it was the ORS, and I said we have to physically get down, and I'm too old to bend over, so I would just get down on my knees, but we had safe equipment. So you get down, help everybody to sit up. The babies, you just pick them up, and you help them to drink the oral rehydration solution. That's what you do. So it's like Sierra Leone. There's no. You ask yourself, should I leave? Should I stay? What can I do if I stay? You have to come up with solutions. They're not necessarily good, but maybe tomorrow they'll be better. But you have to apply the best solutions that you can come up with, and that's what we did. And I realized the patients who are stronger outside of the tents, they don't really need me like the patients do inside, so don't need us. So the healthcare workers. So we just spent our 45 minutes with patients inside the tents, and then I realized the pre-survivors outside the tents here, what I started doing is doing sort of outpatient rounds. I'd say, we're not even wearing PPE. I'm standing inside the nurse's tent. These guys, you say, just come up and talk with us. Like, what do you need? Some clean clothes, you want some better food, you want new batteries from the radio. So we could spend 5 minutes with each one of them with no PPE on at all. Before, I was spending a lot of time with PPE, talking to them inside the hot zone area, not spending as many minutes as I could with the patients that were, going to die inside the tents. So I'm going to go ahead and wrap up and take questions, but I want to finish with a series of pictures here. So someone at MSF in the beginning of October, not me, and I don't know who it was, they had this brilliant idea of creating a white panel or white wall. It became known as the survivor's wall. So people who survived, they were able to put their hand into a color of paint of their choice, and then put their handprint on the wall, and then have their name written on the wall if they wanted to. And almost everybody did, a few people didn't. And then also I decided to bring the children together. So there were 10 tents, 8 of which were contiguous, including the 4 that our team was responsible for. And there were children here and there, but children are like the same everywhere. They like to be with one another, they help each other, they play, they help each other drink, eat. And usually we'd have 1 or 2 adults who would be in the chairs or nearby who would be watching over them. And it helped children survive. We gave everyone a stuffed animal, all the children when they were inside, but then they had to be burned, of course, they can't come out. And then we give them a new stuffed toy when they came out. It's always very hot there. And again, MSF workers from around the world, from Australia, from Uganda, from Afghanistan, from Brazil came to work. The psychosocial issues and stigmatization and depression were profound. We had one child who was 10 years old who made drawings every day in the hot zone. He's making drawings. Beautiful. An Italian nurse I worked with gave him the paper and colored pencils, but of course all the drawings had to be burned. Can't come out. So my kids would laugh at me, but they say my level of IT sophistication is I reached not over the orange fence, but close to it, and enlarged my cell phone camera and took pictures of the drawings. And then we had them enlarged and laminated, and when the 10-year-old boy survived and he came out, we gave him copies of all of his pictures as a leaving gift. It's always a joyful day when someone survives Ebola. It was almost as joyful for the nurses and physician assistants and the doctors. And there was a celebration for every patient who survived. Children need a lot of help, but they give a lot back. It's incredibly inspiring and gives you a lot of strength and resiliency you see patients survive, and I'd say especially children. So one panel went to 2, went to 3, went to 4 panels, and one of our survivors, Salome Karwa, came back to volunteer to work mostly with children who had Ebola, and she was on the cover also of Time magazine. This is a poem written by one of the Liberian healthcare workers, 25 years old. He had his birthday when he was there, and he kept a computerized list of every patient who survived, the name, the gender, the age, the date at which they were discharged. And every day there was more survivors, he added more names to the list, and pretty soon we had 74 survivors. And we put them up at the entrance to the nursing tent and at the exit where you looked out, where I showed before where the patients were, at eye level, because that's why we're here, to help patients survive. And afterwards I went to work a little bit at the Ministry of Health, and then went back on spring break in March, where they had this wonderful ceremony. Now, there were no more patients at this facility. In fact, they took the 8 small tents that were so hot, and they tore them down. They dug a huge hole inside the hot zone, because nothing could come out, and they burned them. And they had a big ceremony, and they asked survivors to come back and to light the fire to burn them. It was, for me, a closure in a sense. It was so wonderful to be able to go back and see no more patients, the tents are burned. And then on March 11th is a Remembrance Day, or Memorial Day, or they call it Decoration Day, where you go to the graves of your family members and you honor your family members. But there are no graves for the Ebola patients, right? Because they were cremated. So MSF had this large area like this with, as you can see, a white cover. And then they had many, many, many individual flowers on the ground next to the tables. And they invited people to come and put a flower on the table. This is what the table said: "In loving memory of all those who died of Ebola, may their gentle souls rest in perfect peace." And there was this beautiful ceremony that went on for about 4 hours by Liberian nurses, family members. A lot of survivors came back. And for me, it was very poignant to be able to be there to see a number of the survivors from our 4 tents. And so there was tremendous dancing, singing, skits, and a lot of crying, a lot of grief over those 4 hours. But it's, again, one of the most beautiful days and experiences of my life. These are 6 of the healthcare workers that I worked with. The poet, Kennedy, is right over here. This gentleman is the head of the pharmacy. This person here is the head of the, she was the chief nurse of our unit. This is another survivor who came back to work to help with the children. And the last thing is, the epidemic is not really over because now the survivors have a lot of chronic problems, joint problems, muscle problems, depression, sometimes a lot have eye problems. And then the children, the orphans, how do they get back into school? So on either side of me, right and left, are healthcare workers. The gentleman on the left, Jackson Nema, I worked with every day for 42 days and some nights. And they started an NGO to help children get back into school. So they took me to the school, a 2 hours ride, and to get there, and they took me to all 12 of the classrooms to meet the teachers, to meet the students. And I'll just close with this picture. Some of the students from the school who either are orphans or who who survived Ebola themselves. So I'm going to stop there and take questions. Thank you very much for your time and your attention. So, thank you. So I did speak a little bit longer than I intended to, but if there are questions, and I think Dory has the microphone, I'll defer to her as to who speaks first, second, third.
My first question is, what was the reason that you could only spend 45 minutes?
Yes, so because of the extreme heat with the very heavy personal protective equipment, the MSF personal protective equipment, PPE, was I think heavier than what World Health Organization or certainly what I had available in Freetown in August. In part we had it was very heavy. In part we had this very heavy apron in the front that came down to the knees, which I think that was a good thing because when you face somebody, again, it's about body fluids. So people vomit on you, people vomit, and you're there if you're close to the patient. So you have this big heavy apron on top of everything else. You wear these big boots. I don't always wear double socks in the morning, and then a third sock set when I get out because you don't want your feet to get macerated and get it was very hot. And then although it's not airborne, MSF has required 2 masks, but they weren't to prevent airborne. They were just physical barriers on top, besides your goggles and your hood, no exposed skin whatsoever. And so the 2 masks, it just made it a little bit harder to breathe. And you knew when it was that you'd stay too long when your outer mask would do that collapse and expand. And when you saw that, then it was, your safety is my safety is our safety. You tell the person, leave now. Because it'll still take you 12 to 15 minutes to get your equipment off safely.
So that a lot of the protection was to protect yourself.
Absolutely.
So what about if you had someone, you talked about one of the workers who came back after they survived it?
Yes.
Once they survived it, would they be able to spend longer time and not have to worry as much?
Yes, and that was very important. It was decided they still needed to wear some personal protective equipment, not to protect them, but to prevent them from getting virus on their own clothes or their skin or something, and then potentially spreading it outside of the Ebola treatment unit. It made a huge difference. So initially on October 7th, survivors came back, including Salome, who's on the cover of Time magazine, and then in November there were 4 more. Really, in a sense, they're like the stronger help. They are the stronger helping the weaker, but they fully recovered. There's a very strict screening process that MSF has to allow survivors to come back in because it's very traumatic. Of course, I mean it's traumatic. It's traumatic. I'd say it's more traumatic for the survivors. You know, you go back into the tent, and some of them talked to us about it. You go back into the same tents where you were a patient, where you had family members that died, where you saw your friends, and you got to really, really be strong psychologically to be able to come back and help.
Dr. Lucey, is the vaccine a live attenuated virus then that they're looking at this point?
Bill, thank you for that question. I didn't have time to get to even more recent news. So no, it's definitely not an Ebola vaccine that's being tested, and there are several of them. None of them are live attenuated vaccines. And personally, I would not favor that, just like I would not favor an HIV attenuated live vaccine. No, never, no. So the one that you heard about probably, it was in the news, it was tested first in Guinea. It takes just a protein from the surface of the Ebola virus, so not the whole virus, so you cannot get Ebola from the vaccine. And it stimulates the immune system. It's the part of the Ebola virus that stimulates the immune system, we think, most effectively to induce a protective immune response. So there was a study done where people who were exposed to patients with Ebola were given the vaccine either right away or after 21 days. So 21 days is the maximum amount of time, the so-called incubation period. If you don't get sick after you've been exposed in 21 days, then you're not going to get it. So everybody got the vaccine, but there was an immediate and a delayed group. There was no placebo in the sense of giving a placebo or some other vaccine. Everybody got the Ebola vaccine, but some people got it after 21 days, and some people got it right away. And what was shown was that if you got it right away, then you're much, much, much less likely to get Ebola during the course of the 21 days. But that's very short term, sort of after exposure. It's not getting the vaccine before you're exposed. Like, if you're going to go to work there now, you get the vaccine now. You don't know how long the protection is going to last. 3 weeks, that's good. I'm sure it's more than 3 weeks, but how much more? So we still have a long way to go. And then there's other experimental Ebola vaccines. Like the US NIH tested one in Liberia, but by the time it appeared to be safe and stimulated a strong immune response, but by the time that we're able to go into a so-called phase 3 or the final big efficacy study, there were no more patients with Ebola in Liberia. So that's good, but you can't prove that the vaccine worked.
Could you comment on use of antivirals or monoclonal antibodies?
So there's still no licensed antivirals for Ebola or monoclonal antibodies, but much like the vaccine, which also, all the vaccines are not licensed at this point, there is some certainly encouraging anecdotal, if that's not a contradiction of terms, encouraging small numbers of patients who have received either monoclonal antibodies against the Ebola virus or polyclonal plasma or polyclonal antibodies from the plasma of survivors with or without antiviral drugs. And I think that most of the patients treated in this country, I don't know that it's everyone, but most of them received one or the other or both. That is immune-based antibody therapy or polyclonal, monoclonal, and or one or sometimes more than one experimental antiviral drug. That said, we still don't know if they work because it's been too small numbers of patients and it wasn't necessarily a randomized controls trial. So there's hope, and what I think most importantly is that continue to do the research on the vaccines, the antibody treatment, and the antiviral drugs so that we know what really is effective and what the side effects, the adverse effects are, so the risk-benefit ratio, because there will be more Ebola outbreaks for sure. Why? Because the virus lives in the animals. It lives in multiple species of animals. We know about multiple species, and there's probably others that we don't know about. And that's how people get infected, exposure to the body fluids of the infected animals. That's why there's been 24 outbreaks. Yes, sir, please.
It seems that you already gave a partial answer to my question. Is there nowadays a better understanding of the evolutionary biology of the virus?
So that's a very important question for several reasons. And the answer is yes, there's a partial understanding. So for example, what do we know? And what do we need to know? What do we know is that there's 5 different, what we call species. I used to use the word strain, but that's wrong. It's species of the virus. There's the Zaire virus, which is what first appeared in 1976, the first outbreak in Zaire, the Democratic Republic of Congo now. But also that's what caused the outbreak in West Africa, a variation of the Zaire strain. But there's other ones, the Sudan strain, the Bunyamanga, there's Western Virginia strain. But what we're really worried about, and that hasn't happened yet though, by looking at the evolutionary biology or genetics of the virus, is it going to mutate in a way that makes it no longer responsive to our experimental antiviral drugs or antibodies or vaccines. So still a lot of work to be done, but a lot has been done. Yes, sir.
I have a quick question about, you know how many of sequelae of this virus in survival you have noticed so far in eyes, in body, in liver, or whatever? And number two is, how long a person can be a carrier of this virus? For example, if she or feels good but still can carry the virus and give it to somebody else.
So again, you raised an important point that I didn't have time to go into that we've learned a lot about just in the past 6 months or 8 months. And I saw some of the survivors went back in March, and there are some common means what, 30%, 40%, 50% sequelae. So most common ones are joint pains and even swelling and even loss of function, especially in the knees, but also muscle pains, both of which occur during the acute phase, but then they can become chronic, hopefully not permanent. The other common side effect is, or persistent problem is impaired vision. And again, that happens acutely, but it also happens over months, sometimes leading to blindness. There's an American doctor, Ian Crozier from Sierra Leone, who was infected. He was hospitalized in Atlanta. His picture, he survived after being on a ventilator and kidney dialysis. He survived. Only a couple months later then to have the virus found in his eye. And he's blue-eyed, and one of his eyes changed to a green color. And it was on the front page of the New York Times and in the New England Journal of Medicine. And as far as carriers, I don't know of anyone who, it depends on how you define carriers. I don't know of anyone who's been shown to have the virus in the blood for months, no. But obviously, Dr. Crozier had the virus in his eye. It wasn't in his tears, and it wasn't in his blood, and it wasn't in his spinal fluid. So the risk of him infecting somebody else was very, very small. But then he got experimental treatment, and what if he hadn't? I don't know, would have gone to his blood. But what's really worrisome is last month, October, there was a nurse from the UK who got infected in December in Sierra Leone, came back and was in intensive care in London in January and recovered. The virus was gone from her blood. She went back to work. She worked for 8 months, 9 months maybe. And then October, suddenly she started feeling sick again. And then what was found was that she developed meningitis, Ebola meningitis. Now, we suspected patients had Ebola meningitis, but if you can't give out intravenous fluids, you can't do a lumbar puncture, and you can't, we never could do that. But she had virus found last month, after 9 months or so since January, in her spinal fluid, but also in her blood. So yes, she could be, in theory, she could be contagious. And what happened was, to get back to Bill's question earlier, the vaccine, the experimental vaccine that was offered and studied in Guinea and then offered in Sierra Leone was offered to people in the UK who had been exposed to her when she presumably had the virus in the blood. So I'd say that's another example of why West Africa really matters, what happens during the Ebola outbreak. I was asked that question on CNN last September. I said, because they're human beings like we are, and also because someone's going to get on a plane from one of the capitals and fly to our country. But here's another example. I'd say we learned about a vaccine that might work after someone's been exposed to the virus, and that was offered in Guinea, in Sierra Leone, and now this past month in the UK.
Sir?
Oh, yes, ma'am.
Yeah, what kind of oral rehydration solution did you use, and could you have given it to the people outside the fence that couldn't get in?
Yes, ma'am. So it was a standard oral rehydration solution called ORS. It's the exact same oral rehydration solution as water, sugar, sodium, and potassium that's given to patients with cholera that saves patients' lives with cholera. And honestly, until you asked that question, your question never crossed my mind. And again, I'm not just embarrassed, I'm ashamed to say that. Even though I wasn't there at that time, I still should have thought of that until you just now asked me what. Yeah, Gatorade's a little bit different, but the concept is a very important point. No, we didn't have any Pedialyte. Oh, could they? Shh. I think that's another very good idea. Another very good idea. I think we really need to, yes, so Pedialyte. Has to be. That's right. Yes, that's right. So for me, this is a very important point about this epidemic. That,
This is going to be the last question.
oh, sorry. Sorry.
What is known about the persistence of Ebola virus in seminal fluid?
A lot more than was known before this epidemic. So prior to this epidemic, it was known to be present, in semen up to 84 days in one person. So we actually, MSF at this Monrovia Hospital Ebola treatment unit, we gave every survivor 90 condoms, male, female, 90 condoms. But what's been reported just recently from a study, I think it was in the New England Journal just in the past month, was that the virus can persist in a minority of patients in men for up to 9 months. Up to 9 months. So, but, I think you could argue, well, the good news is we know how to, prevent unprotected sex, if you will. But it really wasn't appreciated, I don't think, until now that needs to be done for Ebola, as well as for HIV and so many other things.
Thank you, Doctor.
Thank you.
Doctor, on behalf of the Dolan Committee and the Dolan family, we wanted to give you this crystal as a memory of your lecture tonight, and thank you for a very interesting lecture and your dedication.
Thank you so much, so much. Thank you so much.
And as you all know, we have a wonderful reception right by the